Bismillahirrahmanirrahim. I am Professor Shahid Sarwar, Professor of Medicine and Gastroenterology at Allama Iqbal Medical College, Lahore. I welcome all of you on today's academic session. This academic session is primarily meant for undergraduate students, house officers, family physicians, as well as for postgraduate residents in medicine and gastroenterology. Let's start with today's session. Today we are going to talk about hepatocellular carcinoma. What we are going to do is that we are going to talk about its prevalence and incidence. We will talk about the risk factors which predispose to developing hepatocellular carcinoma, and we'll talk about how to look for this particular cancer at an earlier stage through surveillance program. Can we prevent hepatocellular carcinoma or not? And how do we diagnose this? And what are the different staging systems that are used for this particular cancer? And then we will give an overview of the treatment options which are available. HCC basically is a common cancer among the leading cancers in all over the world. And there are certain regions which have got more prevalence like East Asia and Sub-Saharan Africa. It is the fifth most common cancer, and it's the third leading cause of the cancer deaths. And it has got certain geographical imbalance in the sense that in East Asia and Sub-Saharan Africa, almost 85% of cases of whole world are in these two particular regions. Another important thing about HCC is that its incidence is rising in last 2-3 decades. Now, when all cancer deaths are declining in USA between 1990 to 2004, the cancer deaths due to hepatocellular carcinoma were rising. And the reason for this that were identified are: one is immigration of more and more patients with viral hepatitis in USA, then rising incidence of non-alcoholic fatty liver disease, which is now becoming a leading cause of liver cirrhosis and liver transplantation and cancers, and then obviously a generation between which were born between 1945 to 65. They have lived around 30, 35, and 50 and 60 years now. So more and more cancers are being seen in that one particular generation in USA. More than 90% of liver cancers are hepatocellular carcinoma. And one thing which is different about this particular cancer is that in majority of the patients, you do have an underlying cause for it. And around 50 to 55% patients, it's hepatitis B, and in 30% patients, it's hepatitis C. So in 85% of the patients, it's either hepatitis B and C. And again, we see that there is difference in the area-wise difference in these etiological factors as well, that in Asian and African countries, hepatitis B is the leading cause. And in Western countries, it's the hepatitis C, and hepatitis B is not that common in Western countries. So what is the risk for hepatocellular carcinoma? The most important is liver cirrhosis. If somebody has liver cirrhosis, then there is 1 to 8% chances of having HCC every year. And with declining platelet count, with presence of esophageal varices, with increasing age, and in male gender, this risk is more. And this is both for hepatitis B and C, though there is a little difference between them, and both viruses have their own factors which predisposes more to the development of this HCC, but this is a risk factor once the patient has liver cirrhosis. Apart from this, exposure to this particular fungus, aflatoxin, then alcoholic hepatitis, then hemochromatosis, alpha-antitrypsin deficiency, and presence of non-alcoholic fatty liver disease, these are common risk factors for developing HCC. For a NAFLD, the risk varies between 0.25 to 7.6%. But the most important thing is that around 50% of the patients with NAFLD who develop HCC, they don't have cirrhosis. So we'll come back to this point later as well. Then smoking and HIV are two other factors which are considered as risk factors. Now, if you know the etiology in 85% of the cases of HCC, that is hepatitis B and C, so then it is possible to identify this particular cancer at an earlier stage because you have a defined risk population which is at increased risk of hepatocellular carcinoma. So let's see how can we do surveillance for hepatocellular carcinoma. So the first question in this is, who should have the surveillance for hepatocellular carcinoma? Obviously, liver cirrhosis patients should have surveillance. And it is cost effective if the risk is more than 1.5% per year. And we know it is more than that in patients who have developed liver cirrhosis. Interestingly, patients of cirrhosis who have advanced to a stage of child class C, or those with child class B but having ascites, beta-renal syndrome, and jaundice, they only benefit from this surveillance program if they are on liver transplantation list. Otherwise, at this stage of disease, the overall survival is so poor that diagnosing HCC at an earlier stage will not make any difference in outcome for the patient. Do we need to have a surveillance in patients without liver cirrhosis? In HCC, it is cost effective at the stage of F3, that is bridging fibrosis. We know patients of hepatitis B do develop hepatocellular carcinoma without liver cirrhosis. But to make a program, surveillance program cost effective in these patients, the incidence has to be more than 0.2%. So a certain population with age more than 40, male gender, certain regions where high prevalence of hepatitis B is present, and those with strong family history, in those patients of hepatitis B, you will start surveillance for hepatocellular carcinoma even without liver cirrhosis. What about NASH? 50% of patients with NASH develop HCC without liver cirrhosis, as I already told about this. But the prevalence of NASH is so high, around 20 to 25% of world population suffering from this particular disease, that doing a surveillance in such a huge population is not going to be cost effective. So right now, by now, surveillance is only recommended in those with advanced fibrosis and cirrhosis in non-alcoholic steatohepatitis. What to do about the patients who have been treated for hepatitis B and C? There is enough evidence to suggest that with treatment and with viral suppression, the risk for HCC does decreases. For hepatitis B, if you are treating with nucleoside analogs, for first 5 years, the incidence of HCC is 3.2% per year. But for next 5 years, the incidence declines to 1.57% in next 5 years with cirrhosis. But despite this decline, the risk is still above 1.5%. So surveillance needs to be continued in patients with hepatitis B, with liver cirrhosis, even if they have persistent viral suppression. Even for HCV, even after SVR, you need to continue your surveillance program in patients with cirrhosis. What about those who have got SVR with the newer drugs and DAs and in hepatitis C? The thing is, if cirrhosis is already present, the risk still remains high. It is around 1.39 to 1.82%. So surveillance is still cost effective in patients with cirrhosis, even after achieving sustained viral response. Though there are studies which are suggesting that tools like APRI-score and FIB-4, they should be used to identify patients who are at higher risk, so that this surveillance strategy may be focused on only on those patients of cirrhosis with higher APRI-score or with higher FIB-4 score. But that stage is still to come in terms of evidence. Is there an increased risk of hepatocellular carcinoma in patients being treated with new directly acting antiviral drugs of HCV? This is the concern and alarm which was raised a few years back. And the concept behind it was that with treatment and with low viral load, immune system gets distorted and there is reduced immune surveillance. And if all patient already has a pre-existing cancer clone, that clone will have more chances of developing and growing and getting out of control to develop into a cancer. And this was based primarily on retrospective data where they showed that patients being treated with DAs, they have more chances of HCC as compared to patients which were treated with interferon therapy. But once the sub-analysis of this particular, these retrospective studies was done, it was identified that those patients who were in DA group, they were more older, they have lower platelet count, they have higher rates of diabetes, and they were at more advanced stage of liver disease. That's why there was more patients of hepatocellular carcinoma. When you take out these confounding variables, the risk of HCC is same in patients with SVR with interferon as it is in patients with SVR with directly acting antiviral drugs. And there is no question about this thing that after SVR, the risk of HCC does decline. You need to continue monitoring in patients with cirrhosis, but it does help in reducing the chances of developing this cancer. So we have a list of patients who should have a surveillance for hepatocellular carcinoma. Asian patients more than 40 years of age, Asian females more than 50 years of age, patients with strong family history and hepatitis B. These are the patients where even without cirrhosis, you are going to do surveillance, and the rest we have already talked about. The next question will be, okay, we have to do surveillance in a select group of patients. How to do the surveillance? Which test should be used? That test has to be an efficient test, has to be a tolerable test, has to be an acceptable to general population, and the availability of that test should be another factor that must be considered before recommending it for the surveillance of this particular cancer. So which tests can be used? Ultrasound abdomen. Obviously, it has got very high acceptability. It's non-invasive. The cost is moderate, and it helps in detecting other complications of liver cirrhosis as well. The limitation with ultrasound is its lower sensitivity. It has got very high specificity, but there is a possibility that a small size HCC may be missed on ultrasound. For CT and MRI, obviously they are more good at picking small size tumors, but the cost is a major issue. You can't use it as a mass surveillance program test because of the cost. Second thing is you will get false positive patients in CT and MRI as well. Alpha-fetoprotein has continued to be used for surveillance of HCC, but it only adds 6 to 8% to the overall outcome if it is added to the ultrasound. And then those with small HCC may have normal alpha-fetoprotein. Another thing is that alpha-fetoprotein may be raised with viral application, even in the absence of hepatocellular carcinoma. So this is no more recommended to be used for surveillance of this cancer. We did a study a few years back, and we identified that alpha-fetoprotein sensitivity is around 70 to 72%. Not good enough to be used as a tool for surveillance of the patient. So surveillance of hepatocellular carcinoma is a challenge which still exists with all the newer modalities. We still see patients at a very advanced being diagnosed with hepatocellular carcinoma at a stage where there is no treatment possible. So how can we handle this situation? Obviously, that needs patient education, practitioners education. We need to involve primary care physician into this. We need to create awareness among them. And then we have to develop systems where we can approach patients easily. We can call them back. We can make facilities available close to them where surveillance can be carried out. Still, we need better tests. We've already talked about that these tests are suffering from lower sensitivity, so the chances of missing hepatocellular carcinoma. And we also need to identify patients who should straight move to CT or MRI instead of ultrasound based on their risk stratification. That system still needs to be developed. Can we prevent this cancer? Because we know the causes which can lead to hepatocellular carcinoma. And one of the causes is hepatitis B, and hepatitis B is a preventable disease. So in a very good and a very large study in Taiwan, it was shown after the mass vaccination program being launched there, over the year, there were lesser risk, lesser incidence of hepatitis B, and that also translated into lesser incidence of hepatocellular carcinoma as well. Then there are studies which have shown that the coffee intake is one thing which can help in reducing the incidence of hepatocellular carcinoma, and now it is in guidelines as well that even taking 4 cups a day is better than taking 2 cups a day. This was primary prevention. What about secondary prevention? We all know if we treat hepatitis B, the risk starts declining after 5 years of treatment. If we treat hepatitis C with SVR, the risk does decline in these patients. Now let's move to the diagnosis. How do we diagnose hepatocellular carcinoma? One rule of thumb is if the patient has got cirrhosis, then the diagnosis is possible with imaging modalities without biopsy. But if there is no cirrhosis, we will have to get histopathology done before labeling patient as hepatocellular carcinoma. So you have got 4 modalities. It's CT, MRI, contrast-enhanced echo, ultrasound, and obviously histopathology. Now on CT scan, these are the 4 cardinal features which are specific and very sensitive for hepatocellular carcinoma, provided the size of the tumor is more than 1 centimeter. One is arterial phase enhancement. Second is delayed venous phase washout. The third is enhancing capsular appearance of the tumor. And the fourth is 50% increase in size in less than 6 months' time. These are the 4 features which helps me in diagnosis. Now, how do I interpret these 4 features? Because obviously I'm not going to get all 4 features in every patient. So what to do if there are 2 features? What to do if there are 3 features? What to do if there is 1 feature which is present there? How I'm going to label that particular patient? For that, this particular reporting system has been developed and is now widely used by the radiologists, liver reporting and data system, which is called DRAD system. So as physicians and gastroenterology, we need to be familiar with this. So what they do is that they label lesions and tumors in the liver as LIRAD 1, 2, 3, 4, 5. Now this is based on presence or absence of these 4 features that I've already told about. Now you see, the most important thing here is the size of the tumor. Is it less than 2 centimeter or more than 2 centimeter? And then you interpret the presence or absence of those 4 cardinal features of imaging modalities. So you see, if somebody has arterial phase enhancement and more than 2 centimeter size, only 1 additional feature out of the remaining 3 will make it LIRAD 5, which is confirmed hepatocellular carcinoma. Then on another side, you see, if the size is more than 2 centimeter and there is no arterial phase enhancement, if patient has 2 additional features, despite absence of arterial phase enhancement, still it can be LIRAD 4, which needs to be discussed in multidisciplinary meeting. So this table should always be kept in front of you before interpreting the CT scan report to see where does our patient falls. Because how are we going to handle this particular tumor depends on this classification. If it is LIRAD 3, I will repeat the imaging modality in 3 months' time. But LIRAD 4 and 5 has to go to the multidisciplinary discussion to decide regarding the fate and the treatment option which is suitable for this particular patient. So still we don't have a 100% test in imaging modalities, and we can see once the size is less than 2 centimeters, the sensitivity is around 70%. So there are possibilities of missing a tumor if the size is less than 2 centimeters. Specificity is good enough, but sensitivity remains a challenge. And that is why now a newer option is contrast enhanced ultrasound. It does not add to the sensitivity, but it has got higher specificity. And especially it helps in differentiating from intrahepatic cholangiocarcinoma. So these are the 3 imaging modalities that you are going to use. And there will be patients in which you will not get a clear-cut answer with imaging modalities. So you will go for liver biopsy, which has got a very good sensitivity and specificity. And now we have got immune histochemical analysis as well, which may be used in future in deciding the type of treatment to be offered to the patient. Biopsy does have a risk of bleeding, risk of needle tract seeding, but these risks are limited and it should not stop or hamper us from performing biopsy where it is needed. So in short, we can say if the size is less than 1 centimeter, we'll repeat imaging in 3 months' time. But if size is more than 1 centimeter, either we are going to use triphasic CT scan or we are going to see contrast enhanced MRI. And if one imaging modality is not giving you the clear-cut answer, you will use the second modality. And if both are equivocal, then we'll go for the liver biopsy. That's how we approach in terms of diagnosis for these patients. What about staging? We published a study where we compared different staging systems like CUDA and Grattage and CLIP, and we identified CLIP as a better score, as a better staging system, as it includes CTP score, tumor morphology, alpha-fetoprotein, and presence or absence of portal vein invasion. But the limitation of these systems is that they don't guide about the treatment option to be used for these patients. That's why now we have moved on to either this Hong Kong liver cancer staging system or very popular Barcelona Clinic liver cancer staging system, Bclc staging system. So I'll spend a few minutes on this Bclc staging system because the treatment plan is purely based on this particular staging. This system uses 3 things for staging a patient of HCC. One is tumor burden. Milan criteria, it uses Milan criteria. Milan criteria is single tumor less than 5 centimeter or 3 or less than 3 tumors, none more than 3 centimeter, and there should be no vascular invasion and no extrahepatic spread. People have extended the limits of Milan. Now use CSF criteria where you will see single lesion less than 6.5 centimeter or less than that, and 2 to 3 lesions, none exceeding more than 4.5 centimeter, and total size should not be more than 8 centimeter. So one parameter in Bclc staging system is tumor burden. The other is ECOG status of the patient. Now that's basically the functional status of the patient. ECOG 0 is fully functional, taking self-care, performing all routine activities, and ECOG 4 is the one who is spending more than 50% on the bed. He is unable to take care for his self-care, and he's totally confined to the bed. So this is how stage the patient regarding his overall activity status. And the third is this particular CTP scoring system. That is basically the staging of underlying liver disease. So Bclc staging system is based on these three parameters. And if somebody has a single HCC of less than 2 centimeter and CTP score A and functional status is 0, this is stage 0. Somebody has tumor within Milan criteria with functional status of 0 and CTP class A or B, this is stage A. If multinodular HCC with CTP score A and B and functional status 0, it's stage B. If the tumor has gone beyond, it has got vascular invasion or it has got extrahepatic spread, patient's functional status is 0 to 2, and child class score stage is A or B, then it is stage C. And beyond that is child class C or functional status 3 or 4, and very advanced tumor will be stage D. So using those three parameters, we first have to stage the patient into stage 0, A, B, and C and D. Once we have done that, then we can easily decide regarding the treatment option. If somebody is stage 0, that means it has got a tumor of less than 2 centimeter, he has got CTP class A and functional status is 0. That is a patient who is an ideal candidate for either resection or for radiofrequency ablation. Even at this stage, people have further classified as vaguely nodular and distinctly nodular. The importance is that in distinctly nodular, though the size is around 1.5 to 1.6 centimeter, but 25% of these patients are going to have portal vein microinvasion. So how do I decide between resection and radiofrequency ablation? If patient is a candidate for liver transplantation, then resection is a better option, because once I take that tumor out and get the histopathology done, I may come up with a tumor which has got poor differentiation, or there is microvascular invasion, or there are satellite lesions. That patient can be straight away recommended for liver transplantation, because that creates an ab initio indication for liver transplantation. But if patient is not a candidate for liver transplantation, then in stage 0, radiofrequency ablation is the best option, because it is cost effective. And the 5-year survival at this stage is very good. It's around 80 to 90%. Once you move to stage A, which is within the malign criteria, but has got child score stage A and has got a very good functional status, even at this stage, median survival without treatment is around 36 months. And 5-year survival with treatment does increases to 50 to 70%. So what are the options of treatment for me? Radiofrequency ablation, resection, and liver transplantation that has been added at this particular stage. Interestingly, if somebody has a tumor of more than 5 centimeter, which takes it beyond Milan criteria, but there is no ascites and bilirubin is normal and hepatic vein pressure gradient is less than 10, even these patients can benefit from resection as well, despite being at a stage which is even not stage A, it's a stage B. So there will remain these vague areas, these gray zones where decisions has to be made at multidisciplinary meeting according to the status of the patient. Then is the stage B, which is beyond Milan criteria. Size is more. Here the median survival is around 16 months, 2-year survival is 49%. Primarily the treatment is local regional. PACE and radiotherapy and selective radiotherapy, which is delivered at the site of the tumor. These are the primary treatment options at stage B. And median survival increases from 16 months to 40 months if we give some form of treatment. But again, this is a very heterogeneous group, and there are so many gray zones. You will find patients in stage B which can benefit from liver transplantation. What you do is that you downstage those patients. Stage B patients, you give a PACE treatment, and if patient's tumor size is reduced and that remains stable over a certain time, that patient may be a candidate for liver transplantation. And then I've already talked about a patient with a single tumor of more than 5 centimeter and no parameters suggesting of advanced liver disease. He may be a candidate for a section as well. But then there will be patients of multifocal tumor, multiple tumors spread all over the liver. They are stage B, but they can't be treated with local regional therapy. The only option for them is chemotherapy. So this group needs further subdivisions and obviously subclassifications to decide the treatment in this particular group. Stage C is the one when the patient has extrahepatic spread or patient has got invasion into the portal vein. But still, it has to be CTP class A and B and functional status 1 to 2. Primarily, the treatment is chemotherapy at stage C. Here, the treatment, the survival without treatment is around 6 months. And with treatment, there is marginal increase of 2 to 3 months in survival of the patient. Stage D is the end stage disease where you are only going for supportive treatment. Here survival is only 1 year survival is around 11%, median survival is 3 months. Now, this is the latest table of Bclc which has been released. Obviously, there are modifications going on in this particular table to make it more and more comprehensive. So this looks much more comprehensive. You can see for stage 0, the primary option is ablation and section, depending on that the patient is candidate for transplant or not. Once you're dealing with stage A, the primary option is liver transplantation if the disease underlying liver disease has progressed. But if underlying bilirubin is normal, port pressure is normal, still the resection and ablation can be done. But you see, in this, there will be certain patients who will not be candidate for any of this option, and there you may opt for TACE to give some form of treatment, some form of improvement in survival, even at stage A. And then you see in stage B, they have covered that part that one is extended Milan criteria. They can go for liver transplantation. The second is they get a TACE done and successfully downstage the tumor. Still the transplant is a possibility in stage B. Otherwise, local regional therapy is the primary treatment for stage B. For stage C, the primary treatment is chemotherapy, which is fast evolving in last few years. And we now need to see that the first line treatment option is the combination of atezolizumab and bevacizumab, along with sorafenib or lenvatinib. But that combination of atezo and bevi is now becoming more and more popular because of the better results. And if the patient is not responding to these first line options, then you have what second line options like regorafenib and cabozantinib and ramucirumab for those who have got alpha-fetoprotein levels more than 400. And then there is a third line option as well, cabozantinib, which can be used. So chemotherapy is the field which is fast evolving in hepatocellular carcinoma, and it has shown a lot of promising results in last few years and should be kept an eye on. And if we walk across different societies and their recommendation, we will see there is not much of a difference. Grossly, the plan will remain the same. For stage 0, it's a resection and ablation. For stage A, transplantation, resection, ablation. For B, local regional therapy, and few of them can be downstage, move to the liver transplantation. For C, chemotherapy is the main primary option. For D, the treatment is supportive as per all the society's guidelines. Lastly, 1 minute on this, response evaluation criterion, solid tumor. This is used to document what response has been noted with the treatment. Because now we are using treatments which are not curative, like TACE, like radiotherapy, like chemotherapy, where the disease may not disappear, but there is some form of response. So you need to label that. So complete response is when the disease disappears. Partial response is when more than 30% decline in the overall disease. And if there is 20% increase, you will call it as progressive disease. And if it remains stable, you will call it as stable disease. So these labels and their definitions now we need to remember because they are increasingly being used after the treatment of these patients. So ladies and gentlemen, we have come a long way from diagnosis, from serological markers, from imaging studies, then liver transplantation, and last few years have seen a lot of development in terms of chemotherapy, and new drugs are coming forward with which the outcome has started moving better and patients have started surviving better with hepatocellular carcinoma. So in summary, we can say it's a leading cause of cancer-related morbidity and mortality. And because the etiological factors and the underlying cause is well known in majority of cases, so prevention and treatment is still something which can help in reducing HCC and its burden and its mortality. Then effective implementation of surveillance strategies is needed because that will help in early diagnosis of the treatment at a stage where better treatments can be given, as we have seen through this treatment in Bclc staging system. The lesser the size, less advanced the stage of the disease, and the better functional status, that will ensure better treatment options for that particular patient. And these decisions of treatment should never be taken in isolation. It needs a multidisciplinary treatment plan. It should involve a hepatologist, surgeon, interventional radiologist, and oncologist, because everybody will need to contribute at some stage of the disease for that particular patient. So right from the day one, all need to sit together and make decisions for these patients. Thank you very much. I hope this particular session would have helped you in understanding hepatocellular carcinoma, its implication, how to handle it, how to do surveillance, then how to stage this particular disease, and how to select the appropriate treatment option for this particular cancer. Thank you very much.